All right, let's begin. I want to thank all of our NAAOP members and friends for joining this webinar. We have I think, a very solid presentation today on a very important topic for all orthotic and prosthetic providers, and frankly, all providers that participate in the Medicare program. Today, we're going to hear from our president, Maggie Baumer, Kate Petalhone, the 2023 Brees Fellow, Nate Capa, who is an NAAOP board member, Leela Baggett, my senior associate here at the firm Powers Law in Washington, D.C., George Brees, our executive director, and myself. So I think we can begin with respect to the slide deck and posting of the slides. Thank you. Let me start by saying first a disclaimer. I have to do this. The presentation we are providing is accurate and authoritative information on the subjects that will be covered, but it is not to be considered a full legal analysis or a comprehensive legal analysis, and it should not be relied upon as rendering legal advice. It's important that people understand that. Having said that, I do think you will learn something today about new rules for O&P practitioners to challenge Medicare Advantage denials of orthotic and prosthetic care. Moving on to slide 3, I'd like to quickly relate the agenda. First, we're going to go through some introductions. We're then going to talk about the purpose of the webinar. We're going to gain the perspective of O&P practitioners through our board member, Nate Capa. We're then going to talk about this setting of the stage for Medicare Advantage and prior authorization. So this is kind of the background about how this issue arises and where it came from, and the context for what you're going to hear in, unfortunately, excruciating detail when we talk about the new rules for providers and patients to challenge Medicare Advantage denials. This is an important rule, and it's the first time that CMS has really embarked upon setting some standards in this area. And it's one of the reasons we feel this webinar is very important for the field. We'll then do some Q&A, so we'll try to get through in time for some questions and answers, and then George Brees will deliver some parting remarks. So let's move to our president. Unfortunately, Maggie Baumer was not able to join us live today, but did record a video, and I'm going to ask for that video to be run at this point.
Good afternoon, everyone. My name is Maggie Baumer, and I'm the current president of the National Association for the Advancement of Orthotics and Prosthetics. Thank you so much for joining us on the webinar today. You know, for years, we've been hearing from our practices and members about unfair Medicare Advantage plan denials and the issues that causes for both patients and practitioners. So we were really excited to hear about CMS publishing new regulations to put some guardrails on the Medicare Advantage plans. The purpose of this webinar is to distill that information down into digestible bites so that you can challenge those Medicare Advantage denials. Thank you again for all of our members for joining the webinar, and for our non-members, we encourage you to join the NAAOP at naaop.org. That way you can gain greater access to our resources and continue to support the advancement of government relations and patient protections in orthotics and prosthetics. Thanks everyone, and enjoy the webinar.
Excellent. Thank you so much, Maggie. We appreciate you joining by video. Next, I'm going to introduce Kate Petalhone, who is the 2023 NAAOP Brees Fellow. Kate?
Hi, everyone. My name is Kate, and I'm honored to say that I'm the 2023 NAAOP Brees Fellow. I've been having a wonderful summer here in Washington, D.C., learning about O&P legislature, and I'm happy that you all joined this webinar to learn more about this important issue.
Excellent. Kate, give the members just a little bit of your background and your understanding of orthotics and prosthetics.
Awesome. I will, Peter. So I have been a lifelong amputee, basically. I contracted sepsis when I was 8 months old, which resulted in me losing parts of my feet, losing my left hand, and have partial fingers on my right hand. As a result, I've been wearing orthotics and prosthetic combos on my feet my whole life and a prosthetic hand. So O&P care and having it accessible to the whole population is a very important issue to me.
And Kate is modest, but Kate is a rising junior at Johns Hopkins University studying pre-med. All right, Nathan Capa, please, would you introduce yourself?
Hi, my name is Nathan Capa, and I'm a certified prosthetist with Bremer Prosthetics, which has offices across mid-Michigan. And I'm the past president of the Michigan Orthotics Prosthetics Association and a current NAAOP board member.
Great. My name is Peter Thomas. I'm the general counsel of NAAOP. I'm also the managing partner of Powers Law Firm and do a considerable amount of work with the Orthotic and Prosthetic Alliance, which is a coalition of 5 of the major national nonprofit O&P provider organizations. Leela Baggett.
Good afternoon, everyone. My name is Leela Baggett. I'm a senior associate at Powers Law Firm, and I have had the pleasure of working with Peter Thomas for the past 8 years on orthotic and prosthetic matters, and I'm very happy to be here today. I specialize in Medicare, so happy to discuss the matter.
You're very kind, Leela. George, why don't you go ahead?
Yes, I'm George Brees, Executive Director of the NAAOP, and I too want to welcome everyone today, and we look forward to this webinar and maybe chatting at the end.
All right, so let's go to slide 5 and begin the presentation. Before we begin, let me just also say that rather than feeling that you need to take notes or anything, you can take notes, of course, if you wish. But this presentation is being recorded, and we will have a link to it on our website, naaop.org. So don't feel you have to scribble down kind of everything that's on these slides. I'd prefer actually that you really focused on the slides now in real time and what we were saying to try to really understand what these new rules are. I'd also suggest that some of these slides are going to get kind of dense. You may very well need to revisit them. And they have citations in them. In fact, we'll try to figure out a way to provide the written, a document in terms of this slide deck so that people can download and print that or save it in their electronic file so you can refer to it later on. The whole purpose of this webinar really is to provide O&P practitioners with additional resources, arguments really, to enable you to use citations to the new regulations, specifically citing chapter and verse of the regs or the Federal Register to secure coverage and payment for your patient's services. And this is there's a whole new toolbox of arguments that you will be able to make as a result of this prior authorization and Medicare Advantage set of new rules. CMS issued these new formal rules essentially to rein in the overuse and misuse or abuse of Medicare Advantage plans of prior authorization, just denying claims and putting the burden on practitioners to appeal, putting the burden on patients to appeal those denials before getting care. Many times there's delays that's created as a result of that, or oftentimes denials of specific types of O&P care. So again, we're hopeful that this will provide you with a new set of tools with which to operate moving forward. Let me first turn it to Nathan Capa, who will provide some perspective from the provider perspective.
So thank you, everybody. Thank you, Peter. I'd like to kind of start by just giving you a little background and mentioning that I've made the decision in my clinics to be very selective with the Medicare Advantage plans that I do participate with. So some of the horror stories that I've experienced over the years may be a lot different. And I'm sure if I crowdsource this with all the clinicians that are on the call right now, we could hear some stories that are just terrible. But as a poor result to limit what Advantage plans that we take, because we're really limiting patient access at that time. So this isn't a good result. So hopefully these regulations really help patient access. But I wanted to talk about the fact that, we've seen insurance companies and Medicare Advantage plans specifically use prior authorization to create what I would call routine denials of certain procedure codes. One procedure code that I've seen is the 5704, the protective cover for a transtibial prosthesis. There's a specific Advantage plan that we work with that deems these to be cosmetic despite preponderance of evidence, in cases where they would be necessary, things like geriatric patients in a nursing home with incontinence, where this is really a hygiene issue, not a cosmetic issue. Being able to use a solvent to clean a protective cover is much more hygienic than having things get into a foot shell and on a Spectra sock and those things that the staff at the nursing home or the patient themselves can't clean on their own, versus something they could. Or have even had cases where someone worked as a part-time janitor in a painting facility and had to use caustic chemicals regularly that cause corrosion of their prosthetic components. These cases were still denied as unnecessary because the procedure is cosmetic in nature only. So at that point, we have to look at it as a routine denial, and they're not actually looking at the information that the LCD would use to support the need for the service. Another thing that we've seen is using prior authorization to arbitrarily assign K-level determinations to procedure codes that don't have K-level determinations, such as saying ultralight materials can only be provided to someone who's a K4 level ambulator. We all know that that's not going to be the reason for the need for that kind of service for people. We see lots of onerous appeals processes. We just recently ran into one where we received a denial and we had less than 24 hours to schedule a peer-to-peer review. These are things that impact our ability to provide care for other patients. They disrupt us on an administrative level. They're just things that prevent us from being able to provide necessary services to people. And then the last thing that we've really seen in our clinics a lot is using prior authorization for what we would deem like replacement supplies, such as silicone liners or suspension sealing sleeves, things of that nature, or point of service modifications when someone comes into the office with a wound on their limb from the prosthesis that they're using, and we're still required to get prior authorization to make a modification for a prosthesis or that has already been approved, that we've already received prior authorization to provide the prosthesis. So the routine care should be covered under that initial prior authorization. Like I said, I'm sure there are several other examples of this and we all have our own horror stories, but I'm really happy to kind of kick things back to Peter now so that we can start to talk about what are some possible solutions to this and what can we look forward to in the future.
Thanks so much, Nate. All right, so let me try to set the stage for reform of Medicare Advantage prior authorization and some of the other utilization management techniques that MA plans typically use. When I say MA, it means Medicare Advantage. When I say PA, it means prior auth. I don't know whether most people are aware of this, but just this year, CMS announced, the Centers for Medicare and Medicaid Services announced that over half of Medicare beneficiaries are now covered under the Medicare Advantage plan. This is a major growth in that program. If you recall, over the last 20 some odd years, since 1997 actually, Medicare Advantage has steadily been growing, in part because they offer additional benefits. Congress allowed them to offer supplemental benefits that are not covered under the fee-for-service or traditional Medicare program. And so people are attracted to that, and the program continues to grow. That means that the number of traditional Medicare patients that you'll continue to see will begin to diminish even more than it already has in the future. And that means that the rules that apply to Medicare Advantage are that much more important. There were two seminal reports, one issued in 2018, the other issued in 2022, that the Department of Health and Human Services Office of Inspector General, or the OIG, issued. And both of these reports dug deep into Medicare Advantage plans' use of prior authorization in denying claims. They also studied other utilization management techniques. And they concluded, both reports concluded, that Medicare Advantage plans were misusing and in some cases abusing prior authorization. They were routinely denying claims, putting the burden on patients and providers to appeal those claims. And in many instances, those claims were not appealed because of the hassle factor and the resources it takes to do that. But of those claims that were appealed, an extraordinarily high number of those claims were reversed in favor of the patient. And so this was seen as Medicare Advantage plans really taking advantage of prior authorization, using it to bolster their profits and to ultimately deny services to people who were entitled to receive that care. In fact, this generated so much support on Capitol Hill that a bill was introduced to reform prior authorization called the Improving Seniors Timely Access to Care Act. In the 117th Congress, which was the last 2 years before 2023, the bill was HR 3173 and S 3018 in the Senate. Those bills received, I mean, the House bill received over 362 co-sponsors. That's an incredible number out of 435 members of Congress, and over 52 members in the Senate. That's a majority in both houses of Congress. The bill actually passed the House in 2022, but unfortunately, the Congressional Budget Office determined that it would cost $16 billion over 10 years. Why would it cost money if all they're doing is providing benefits that are already guaranteed and that patients are entitled to under the Medicare program? That's anyone's guess. But the CBO determined that there was a hefty price tag associated with this. It just shows you how much money these plans are saving and putting in their own coffers, distributing to shareholders and executives rather than paying for the care that their beneficiaries have paid for and that taxpayers have contributed to. So additional legislative and regulatory approaches are being pursued. The bill has not yet been introduced in the 118th Congress because they're awaiting another CBO score on a new version of the bill to try to get the cost of the bill decreased. But in the meantime, both the Senate Help Committee, Health, Education, Labor, and Pensions, and the House Ways and Means Committee have both moved forward with including prior authorization provisions very similar to the bill I just mentioned in other pieces of legislation. The markup in the Help Committee was delayed until September, but just yesterday, the House Ways and Means Committee did include a number of prior authorization provisions in the bill that they marked up. Whether or not that gets across the finish line, we'll see. But you can tell there's a lot of enthusiasm to pass something to create some statutory requirements for prior authorization under managed care under the MA program. There's also a separate prior authorization rule pending at CMS that would apply to plans that are much more plans than just Medicare Advantage. This rule would apply to Medicare Advantage. It would also apply to Medicaid managed care plans, children's health insurance plans, and Affordable Care Act plans as well. NAAOP and its sister organizations in the Orthotic Prosthetic Alliance submitted comments in favor of this proposed rule on prior authorization and has sought to really reform this issue. We do believe Congress is poised to push CMS. In fact, they just did a sign-on letter in the House and Senate urging CMS to move forward with publishing that final prior authorization regulation. We expect it to be published in December. So in the meantime, you should know that there was a different regulation that moved forward. NAAOP and the OMP Alliance also supported it. It was published on April 12th, and that really is the basis for this webinar. we're about to get deep into the weeds on what that regulation says. It was a final rule on prior authorization and other utilization management techniques used by Medicare Advantage plans. The rule is effective June 5th, 2023. So these rules are currently in effect. And if you have patients who are being denied based on prior auth or other mechanisms that you'll see in a moment, we urge you to use the information you gain from this webinar in opposing those denials and trying to get approvals for care. We believe that significant regulatory changes are included in this MA rule, and we're very pleased that Medicare has gone forward, CMS has gone forward with issuing this final rule. We think this is a pretty significant blow to the Medicare Advantage industry. Typically, when Medicare Advantage plans go to Capitol Hill, they get a very strong and favorable reception from members of Congress. This is the first time that the pendulum is beginning to swing back, and and maybe leveling the playing field a bit more. And we find that that's actually that's the right direction to go in order to get patients and providers what they need. So let me give you an overview of some of the tools that we're going to be talking about in a moment, and I'm about to pass the gavel to Leela Baggett to walk through some of the details. And let me also preface the next several slides. They are pretty deep in the weeds. There are some specific regulatory and Federal Register citations that you can refer to in your arguments with MA plans and various folks that you're on the phone with to try to get denials overturned. Typically, we don't like to read from slides, but we're going to have to do some of that over the next few slides because the language that they use in the regulation is that important. You need to hear it as they wrote it in the reg. So the 5 or 6 major areas we're going to address include the following. The requirements that Medicare Advantage plans abide by traditional Medicare coverage rules. Very important strengthening of that existing protection. These new rules limit the use of internal Medicare Advantage proprietary coverage guidelines, internal coverage guidelines, some of which they deem proprietary and not available to the public. These new rules will limit prior authorization in certain situations. They'll strengthen medical necessity determinations. They'll establish some guardrails around utilization management tools and techniques and marketing practices. And they'll strengthen the qualifications of claims reviewers who are so notorious for denying claims. And when we clearly suspect that the reviewers just don't understand orthotics and prosthetics. Let me pass the speaker position to Leela Baggett.
Thanks so much, Peter. So as Peter stated, this new final rule discusses coverage guidance. So under existing Medicare law, Medicare Advantage plans, MA plans, are required to provide coverage of O&P care that is covered by traditional Medicare. So when I say traditional Medicare, I'm referring to fee-for-service Medicare. And similarly, existing Medicare regulations mandate that these MA plans comply with National Coverage Determination, abbreviated NCDs, applicable local coverage determinations, abbreviated as LCDs, and other Medicare directive documents unless certain MA plan regulations apply. Notwithstanding the current law that's been in place for quite some time, these MA plans have largely ignored some of these rules. So with the new rule that recently took effect, we'll do is strengthen and clarify existing law to protect providers and that the patients they serve. So under the new rule, MA plans must make medical necessity determinations based on fee-for-service Medicare coverage. That includes Medicare statutes, regulations, NCDs, LCDs, and other Medicare guidance documents. Notably, these directives that would apply to MA plans includes the LCD on knee orthoses, spinal orthoses, ankle foot and knee ankle foot orthoses, as well as lower limb prostheses. MA plans under the new rule cannot deny coverage based on internal proprietary external clinical criteria that is not used by traditional fee-for-service Medicare. So in other words, Medicare Advantage plans cannot utilize interqual or Milliman guidelines to deny coverage or change payment requirements if payment requirements and cover requirements exist in the Medicare program. So there are some caveats. So MA plans are able to utilize internal coverage criteria, so the proprietary or external guidelines that we just were discussing, only in limited circumstances. And that is when coverage criteria is not, quote, fully established under existing traditional fee-for-service Medicare statutes, regulations, NCDs, or LCDs. The definition of not fully established is quite limited, however. That would only apply when there is an absence of applicable statutes, regulations, NCDs, LCDs that are utilized by traditional fee-for-service Medicare. If NCDs or LCDs that apply to the item or service at issue include flexibility and explicitly allow for coverage criteria to be imposed beyond the specific indications used by the traditional fee-for-service set forth in the NCD or LCD. Or lastly, when unspecified criteria are needed to interpret or supplement general provisions in order to determine medical necessity consistently. If, however, MA plans are going to utilize internal coverage criteria, they are mandated to show that the additional criteria provides clinical benefits that are highly likely to outweigh any clinical harm. And that would include delay or decrease access to care. So again, quite limited. And because in the O&P field, coverage criteria is set forth in many LCDs, depending on the actual orthoses or prostheses provided, there should be limited application of internal coverage criteria. Now, when an MA plan is going to utilize internal procedures, coverage guidelines, they have to follow certain requirements. For instance, the new coverage criteria that is used internally has to be based on current evidence that is widely used in treatment guidelines or clinical literature. And that includes acceptable clinical literature that is large and randomized controlled trials, prospective cohort studies with clear results published in peer-reviewed journals and specifically designed to answer the question, the relevant clinical question, or large systematic reviews or meta-analysis summaries of literature in a specific clinical question. Unpublished evidence or evidence that is based on a case series or derived solely from MA internal analysis cannot be used to develop internal procedures.
So Leela, let's take a pause here for 1 second. I'm not aware of any O&P related policy that explicitly grants flexibility to, as the slide noted and as the regulation notes, to provide additional coverage, or it's very rare that you'd have that kind of explicit flexibility. Do you agree with that?
I agree. And I think because of the LCDs I mentioned on knee orthoses, which can be found at L33318, if you're interested in the site, spinal orthoses, which is L33790, AAF and KAFOs, which is L33686, and lastly, lower limb prostheses, L33787. Those directives are quite explicit and delineate traditional fee-for-service coverage criteria, which really does prohibit or at least limit MA plans' abilities to utilize these internal guidelines.
And second, if plans are going to use internal guidelines, it's a pretty high standard. They have to use evidence that's, you know, on the hierarchy of strength of evidence. You know, randomized controlled trials are not typical in orthotics and prosthetics. They exist, they're out there, but there's not that many of them. The kinds of evidence they're talking about really strikes me as being quite complex, quite well developed. Would you say that that's accurate?
It is, yes. And partly what CMS is trying to get at, and has been a complaint expressed by numerous providers across the industry, is that some of these internal procedures that are used, in interqual milliman, for instance, they're not publicly accessible, or if they are, it's quite difficult to access them. So it's not only setting the bar quite high for them to utilize internal procedures, it's also requiring that they be publicly accessible, which is really an improvement to the current system. Which goes to the next slide. So MA plans, I was just saying, they have to provide in a publicly accessible manner the coverage criteria that they're utilizing, their internal, coverage criteria, as well as a
Sorry,
summary.
Paul, go back one side. Sorry to interrupt, Leela. We're on slide 14. Thank you.
Yeah, thanks so much. So they're not only required to publish the internal guidelines that they're using outside the traditional fee-for-service program, but they're also required to publish a summary of the evidence that was considered when they were developing the internal criteria to be used for medical necessity determination. That includes a list of sources of each evidence, and they have to explain publicly the rationale that supports the adoption of the coverage criteria. When coverage criteria is not fully established, the MA plan is also required to identify the general provisions that are being supplemented and further explain how the additional criteria that they are uniquely developing provides clinical benefits that highly likely to outweigh clinical harm. So again, as Peter was saying, it's setting the bar quite high. The coverage criteria has to be not fully established, which is its own hurdle. When internally developing these procedures, they have to meet certain threshold of clinical analyses, and then they have to publicly provide and analyze and justify their adoption of the criteria. So this is really, really putting the MA plans in a position of transparency and accountability, which is ultimately going to benefit providers. So MA plans, when they are making medical necessity determinations, they must rely on certain factors. So under traditional fee-for-service, there is a requirement that the item or service must be reasonable and necessary, so that will still apply. The MA plan must review the patient's medical history, which includes the condition, functional status, diagnoses, physician recommendations, and clinical notes. And I'll say that although the final regulations do not specifically address ONP clinical notes, we encourage your practitioners to argue that that is included in the patient's medical record and should be reviewed by these MA plan reviewers. MA plan reviewers also have to review the coverage and benefit criteria that we were just discussing at length, and where appropriate, the involvement of an MA medical director. MA plans must ensure also that they are making these determinations based on circumstances of a specific individual, so patient. That is important because it prohibits MA plans from using software algorithms that don't account for an individual's circumstances. And we know that there are certain algorithms that have been used in a variety of industries across the healthcare field that are used to try to expedite the medical necessity determination process. And this new rule really hits home the fact that these algorithms or softwares cannot be relied on if they are not taking into account the patient's specific circumstances. And with that, I'm going to turn it back over to Peter to discuss prior authorization.
Thank you, Leela. Great job. Let me move on to prior authorization. The final rule establishes certain safeguards regarding PA, and the reasons that they established this, stated in the regulation, is to avoid disruptions of care, to limit the Medicare Advantage plan's ability to partially approve what a provider ordered, and to minimize repetitive prior authorization. And when they talk about repetitive prior authorization, that's when you go through the process and there's a change of circumstance of some kind, or maybe not, and they come back to you and they say you need to go through PA again. That's where they get into this notion of a course of treatment. They say that approval of a prior authorization request for a course of treatment must be valid for as long as medically necessary to avoid disruptions of care, given the applicable coverage criteria and the individual's medical history, and given the treating provider's recommendation. So if you're in situations, if you have been in situations where a plan is frankly jerking you around, you go through a PA process, you get approval, maybe you get a partial approval, maybe they pull it back and ask you to do it again. That is addressed in this aspect of the regulation. Again, the citation there is important so that you can pull that up. Now, by the way, where do you get 42 CFR section 422 112B81 IA? Google it. Stick it in a Google search engine, and that will come up immediately, and you just kind of take a look at that entire regulation. That is no commercial crass message in favor of Google. It's you can use any search engine you'd like. So when a patient switches from a new MA coordinated care plan or a Medicare Advantage plan, if they switch from fee for service, kind of traditional Medicare into a Medicare Advantage plan, the Medicare Advantage plan cannot disrupt or require reauthorization of an active course of treatment for new plan enrollees for at least 90 days. Now, right now, this is written a bit oddly because they needed to be inclusive. There is no prior authorization of Medicare fee-for-service under the traditional Medicare program. So if you had an individual moving from fee-for-service to traditional Medicare, there'd be no prior authorization to worry about. But if you have someone moving from one MA plan to another, you very well may have that situation. They cannot require you to receive a reauthorization for at least 90 days. And oftentimes that is enough to furnish a prosthesis or orthosis. The requirement also applies even if the service is being furnished by an out-of-network provider. So that's an important new set of guardrails. Prior authorization processes for MA plans may only be used in certain circumstances. This is where they limit how the plans can use PA. Number one is to confirm the presence of diagnoses or other medical criteria that are the basis for the coverage determinations for the specific item or service being provided. So this is a situation that most people encounter prior authorization with kind of private plans, where they use prior auth to make sure that the beneficiary is covered by the plan, that the benefit is a covered benefit, that they are eligible for the care that is being requested, rather than digging into the minutia about whether the actual care being prescribed and provided is medically necessary or appropriate. The second reason goes to that very issue. For basic benefits, to ensure an item or service is medically necessary. So prior authorization can be used for that purpose. And finally, for supplemental benefits, and there is a distinction with respect to Medicare Advantage plans, which can provide not only the basic Medicare benefits package available under traditional Medicare, but also offer additional supplemental benefits at no cost to the enrollee. Those supplemental benefits can also be the subject of confirmation through prior authorization. This is an important paragraph right in the middle of slide number 17. If an MA plan approves the provision of an item or service through a PA request, it is barred from denying coverage later on the basis of a lack of medical necessity. They are barred from reopening the claim and recouping the funds if they've paid it, or from barring a payment in the first place. If you are able to get a prior authorization approval from an MA plan, that should be absent fraud or similar kind of gaming. That should be pretty sacrosanct. You should be paid for that claim, and that claim should remain closed, assuming they would be going after it based on medical necessity. If they're going after it for some other reason, like a fraud situation or overutilization or something along those lines, overbilling, that's another story. But if it's medically necessary during the pre-authorization approval, you've got a high likelihood of being paid and keeping payment. The new requirements should really help in this constant refrain, the incidences that I hear all the time about care disruptions in O&P, denials after the fact, and ultimately misuse and abuse of prior authorization by some Medicare Advantage plans. This slide, the utilization review slide 18, it's kind of a dry slide. We're one ahead here. There you go. It's kind of a dry slide in the sense of what's, utilization review management committee and all that. But there are specific processes that these regulations put into place that require MA plans to follow the rules with respect to the creation of internal guidelines, with respect to the creation of coverage criteria they may use. They have to create a utilization management committee that is led by a plan's medical director in order to develop any kind of utilization review policy or procedure. They're prohibited from using policies and procedures that don't go through that process. And as of January 1, 2024, unless the Utilization Management Committee approves and has reviewed those new processes, claims must be paid. At least annually, this same committee needs to review those policies and practices used by the MA plan. Back to Leela.
Thanks so much. So in addition to addressing the coverage criteria and prior authorization utilization by MA plans, this new rule discusses the qualification of its reviewers who review PA request or claim request and subsequently render an adverse decision. So if an MA plan is intending to issue an adverse PA request or claim based on medical necessity, that determination must be reviewed by a physician or other appropriate healthcare professional. So for instance, a registered nurse that has experience in the field of medicine or healthcare that is appropriate for the services at issue, including knowledge of Medicare coverage criteria. CMS expects that healthcare professional has specialized training, certification, or clinical experience in the applicable field of medicine, including a current and unrestricted license to practice within the scope of his or her profession. Now, if an MA plan reviewer is engaging into a peer-to-peer consultation with a physician during the adjudication process of a adverse PA request, this policy would apply. But there are some important limitations. So MA plans are able to determine the reviewer's qualification on a case-by-case basis of determining what is appropriate based on the services and items that are being requested, and including the relevant aspects of an enrollee's health condition. The final rule, however, does not require that the reviewer of the MA plan be the same specialty or subspecialty of the treating physician or other healthcare provider of the item or service. This was a significant, this was up to significant debate. During the comment period, the provider industry really requested that the reviewer be of the same specialty or subspecialty. CMS said it would not do that because it wanted to provide certain flexibility for hiring purposes to the MA plan so that they can manage clinical staffing resources. But what this effectively means is that a denial of O&P care does not need to be made solely by a orthotist or prosthetist or by a PM&R physician, for instance. And with that, I will turn it back over to Peter.
All right. Well, this last point that Leela made, let me just give you a little bit of commentary on slide number 21. I think this notion of reviewers of claims having sufficient medical expertise to assess the claim before them is a tremendous advance. I believe that is going to significantly reduce the number of just silly denials that come from people that really don't understand O&P at all and are just doing their job or trying to do their job. So that's a very positive development in addition to many of the other things we've talked about today. On balance, this is a wonderful rule for providers and patients, a major advance for O&P practices who are contending with routine delays and denials of O&P care for Medicare Advantage beneficiaries. Given the growth of the program of Medicare Advantage, this is really critical to maintaining access to care in the future. CMS did not wither in response to the proposed rule. They were hit hard by the health insurance industry, by the Medicare Advantage plans, but they held strong. They basically published as strong a rule in the final regulation as they did when they proposed it. And that, I think, does signal a bit of a sea change in terms of how CMS treats MA plans. They've given them free rein for so long. I do think that signals a very positive change for years to come. And finally, I have no doubt that MA plans will continue to search for ways to skirt these regulations, to continue to operate the way they've been operating. I don't view these regulations as a final kind of a set of definitive solutions to some of the problems that O&P practitioners and patients have with MA all the time. But I do think this is a material advance, but they're only going to advance your ability to get covered and paid for your services if you use them, if you know them, if you refer to the chapter and verse. When a Medicare Advantage representative gets on the phone with you and you have a kind of a conversation about a person's denial, for you to be able to say, no, you can't use that rule. That's not the Medicare guidance. That's not Medicare traditional coverage criteria, which you must use under 42 CFR, section 422. If you start citing chapter and verse and tell them, no, you understand, new regulations that apply to you were issued and are now in effect, that prohibit you from doing that. You can't use internal guidelines. What kind of person, what were the credentials of the individual at the MA plan that denied this claim? That's not appropriate. This is what the regulation says about that. That's going to give you some real levers to pull, some new tools to use, not only in your conversations with MA plans, but in your appeal letters for any of the MA plans that you are forced to submit written appeals through the appeals process. So we come to the point in this webinar where we open it up for Q&A. I'm going to refer to the chat function. That's how you, or the, I guess, Q&A function. That's how you would submit questions and answers. And I will ask Leela to assist me with this. In real time, I'm reading a question from Sandra Schechner. AFOs, KFOs, 5-year rule. How will the new rules affect how Advantage plans handle this when they claim they can't see the last MA plan claims? When they can't see the last MA plan claims. Because there was a switch between one MA plan to the next, I presume. Okay. That's a great question. Honestly, I don't know how they'll react to that, but I think that you can use, I think you can use the traditional Medicare rules to argue that this beneficiary needs this care. I know the 5-year rule continues to remain in effect for fee-for-service. That is one of the regulations we're trying to change in the O&P Medicare Patient-Centered Care Act that was added this year to the bill. It was introduced in the House on June 23rd, 2023. Kate Kettelhone had a major role to play in running the NAAOP's virtual fly-in last week, where we spoke with over 50 or 60 members of Congress and their staff about the reg, trying to get orthotics to be treated the same way as prosthetics for purposes of the 5-year rule. But that question is actually a fairly complex question, and I'm afraid I can't give you all that much more of an answer at this point. Leela or Nate, anything that you'd like to add on that?
Yeah, I would just say that, when you are contesting denials, it's important to think about what was the purpose or reasoning why behind this final rule. And it really was to ensure continuity of care so that if an individual is switching plans, traditional fee-for-service to MA plan, or between two MA plans themselves, that there would not be a disruption or a delay in care due to reauthorization for an active course of treatment. So that's why we have this at least 90-day rule, where if there has been a prior authorization that has been granted and the individual switches plans, they cannot require reauthorization for a quote active course of treatment for at least 90 days. So that should provide some comfort to your patient and also help you with provider burden. But when it comes to MA plans communicating to each other, that's something that is not explicitly discussed in this rule, but it's something that the MA plan should be doing amongst themselves, and it may be addressed in other existing law.
And Sandra follows up with another question about, oh, it just disappeared. Let's see. Oh, here it is. Let me see.
And if they grant PA, then can the MA deny later on a 5-year rule?
Right. Well, that's not a rule that pertains per se to medical necessity. That's a rule that pertains to useful lifetime, reasonable useful lifetime, and same or similar denials. So I'm afraid this is a case of first impression. I'm kind of doing this on the fly, but they very well may be able to still deny if we're not able to get that regulation changed through legislative activity. Great question, because it's an interplay between two existing rules. But I must tell you, it's not an easy answer. Let's see, there's another question from Stephanie. When or if the MA plan doesn't honor these rules set forth by CMS after the appeals process, who or where do we report this to? So the MA appeals process is very similar to the fee-for-service appeals process. There's basically 3 levels of review. It's slightly different. All of the appeals steps are spelled out in the plan documents that you would sign onto in agreeing to serve that patient and that plan. But bottom line is that at some point, the review steps out of the plan individuals and becomes more of an independent review. And if you can point to those specific regs that the plan violated and didn't adhere to, that's where you're going to get a lot of these cases overturned, if the plans don't acknowledge and honor those rules themselves. So that's the process that you'd use. Now, if you persistently continue to get shut down and these regs are not working, I do hope that you will contact us and let us know that, so that we can convey that to CMS, because that's a feedback loop that I believe many organizations are going to have with their members. Remember, this is not just a rule that applies to O&P. We've been talking about it as an O&P specific impact, but this applies to any Medicare service in any area. Leila, do you see any other question you'd like to take a crack at?
I'd also just say that certain MA plans do afford an opportunity to file what is referred to as a grievance, which is different than an appeal. It depends on MA plans, but there may be a separate process, and I would refer you to the MA plans provider manual, because that provider manual will discuss whether a grievance process exists and then how to submit that grievance.
There's a question about congressional support for the bill. Yes, the bill is equally supported on the Republican and Democrat side. This is not a partisan piece of legislation. The Medicare O&P Patient-Centered Care Act is intended to be bipartisan, and there were 2 Republican sponsors and 2 Democratic sponsors in the House when the bill was introduced. On the floor of the House, Congressman Thompson, a Republican from Pennsylvania, happened to bump into Pete Sessions, a Republican congressman from Texas, and started talking about the bill. And Sessions ultimately wanted to join on as a original sponsor on the spot. So the bill wound up being introduced with 3 Republicans and 2 Democrats. But either way, it's a very bipartisan bill, and that's the way we intend that to occur, to move forward. Leila, do you have any questions you'd like to pose?
Yeah, so Christina Moore talks about the fact that this new rule went into effect, or is currently in effect, but it was not going to be fully in effect until next year's policy plan, but some of it's already been around an existing law. So she asked, can we begin to use these tips today? You are correct, Christina, that some of these laws, specifically with respect to the fact that traditional Medicare fee-for-service NCDs, LCDs, and coverage criteria must be utilized and employed by Medicare Advantage plan when rendering medical necessity determinations, that is existing law. So I would say if you are receiving a denial where there is a clear coverage criteria set forth in the LCD or NCD perchance, that should be explicitly discussed. Just for if you want a citation just off the cuff, the existing law is referred to as Section 1852A1, as well as 42 CFR Section 422.101. That's the existing law that it was in effect prior to this new rule, and you can include that for your existing appeals. However, the extension and some of the nuance that we discussed is new, but I think some of the traditional fee-for-service coverage criteria, that argument can be made.
And let me just say that the rule itself establishes that this rule went into effect on June 5th, 2023. But they also state that the rule will not be codified into writing until January 1, 2024, when Medicare Advantage plans publish and incorporate these new rules into their plan documents. So the answer to the question, can I use these regulatory changes to argue for my patients today? Absolutely. Let the burden be on the plans to say that it doesn't apply to them, because the rule went into effect explicitly on the 5th of June. I'm afraid we have to wrap up our webinar. There are other really good questions here. We'll do our best to capture them, and happy to try to send out some answers so that people don't feel as though we didn't get to them. If there are additional questions, please email us at NAAOP. Let me turn over the presentation to George Brees, our Executive Director, for some parting comments.
Well, first of all, I just want to thank all who have participated today in this, and in particular, I want to thank Paul Pruzakowski for his behind-the-scenes work on this. But to our members, I want to say thank you. Your support, your friendship, your membership means a great deal to us. In just a few months, we'll be celebrating our 37th anniversary as the National Association for the Advancement of Orthotics and Prosthetics. And if you're on this call today and you're not a member of the NAAOP, we encourage you to join. You can go to our website at NAAOP.org, scroll down right below the video and update. You can support the fellowship if you want. You can join in a number of different ways and become a member of the NAAOP, and we encourage you to do that. Again, thank those who participated today, and for those of you who were a part of this webinar. We hope you have a great day. Thank you.